Hello everyone, welcome to the CKD-MBD program case discussion webinar. I'm Amr El-Husseini, Assistant Lecturer of Nephrology, Mansoura University Faculty of Medicine, and one of tutors and organizer of the CKD-MBD program. The CKD-MBD program is under supervision of Dr. Amr El-Husseini, Program Director, Assistant Professor of Nephrology, Kentucky University. I'd like to introduce Dr. Sayed Burab, Consultant of Nephrology and the Head of Nephrology Department, Al-Kharji General Hospital, Ministry of Health, Saudi Arabia. We have two different cases for discussion presented by Dr. Said. We'll start with the first case. Please, Dr. Said, start sharing your screen. And dear colleague, if you have any question, please put it in the chat box. Please, Dr. Said.
The first case with patient, 34 years, end-stage renal disease, initiated hemodialysis 2006, diagnosed as primary lesions, chronic kidney disease, chronic pyelonephritis, primary lesions, reflex nephropathy, chronic pyelonephritis. This from family history. The patient is a smoker, referred to our unit 2010. History of multiple vascular access failure, and the patient dialysis now on right internal jugular pemphigus. The history of prepared for renal transplantation 2012, but no donor. Our patient clinically is just deformity, big on chest, no additional heart sound, no organomegaly, no lower limb edema. But due to multiple fractures, fragility fractures to the lower limb, there is many deformity. The lower limb bowing outside what's called genioverum, mid-right femur, there's a bulging of metal prosthetic hip joint, hand deformity and swelling of the terminal phalanx. Vital signs stable, history of multiple fracture, right femur, left femur, right clavicle, old rib fracture. Fracture history 2014, fell down the patient fell down and the radiological imaging show fragility fracture neck femur, generalized decrease in the bone density. This is on 2014, only some density. And after that, we will show the progression. Referred to high center and King Fat specialist, operated prosthetic hip joint since February 2014. On 2015, fragility fracture, post minor car accident, displacement of right femur fracture, left femur fracture, rib fracture, clavicle fracture, intertrochanteric fracture. Refer to high center, managed as conservative treatment only. Refer the patient to high centers, but the patient neglected all appointment. About the investigation, renal panel accepted as chronic kidney disease on dialysis. Patient dialysis 3 sessions per week, and adequacy of dialysis 1.7 kT per week. About the liver panel, high alkaline phosphatase, serial assessment above 200, 280 to 300 unit per liter. About CBC, accepted also as a in the stage disease, hemoglobin 11.3. Hematocrit, iron stool okay, stable, magnesium sulfate 1.6, triglyceride, high triglyceride. About the bone panel, calcium 8.9, and sometimes 10, sometimes 9. Hyperphosphatemia, alkaline phosphatase high, above 200. About the parathyroid hormone, high parathyroid hormone all over the investigation. All serial assessment, the parathyroid from 2012 until now, 2,500 picogram per ml, until now 1,500. الميديكيشن البيشنت on سيناكالسيد 60 ملغ, alpha calcidol, calcium carbonate, cefalamir, B12, folic acid, iron, parenteral iron, darbepoetin. We try to educate the patient to stop the smoking, but the patient in compliance, and educate the family how to prevent the fall down and like that. According to this is the patient. The patient just start early of life as a chronic disease, as a chronic kidney disease. 17 years old, start dialysis until now. This is a mineral multiple deformities. This is the bowing leg, what's called genioverum, at the mid of femur, there is prosthetic hip joint displacement, hand and fingers deformity. The patient frequent and recurrent attack and presented with swelling and subside of the terminal of the finger. This right hand and the left hand. Vascular access failure, left fistula. This is a hand on 2020. Only loss of density and subperiosteal resorption and terminal end and the terminal phalanx resorption. The patient in these situations presented with swelling of the terminal fingers. On this situation, the patient presented with mild swelling of the right shoulder and the X-ray show soft tissue calcification. This is the right femur. This is a displacement of the prosthetic hip joint and fragility fracture prosthetic metallic hip joint, and also there is start to appear to cyst in the right femur. The patient complaining of low back pain and lumbosacral done, low of density, and also on December 2020, the patient presented complaining of swelling of the more swelling and the right shoulder, low back pain, swelling the knee joint, soft tissue calcifications appear, soft tissue calcification, and the right femur show cystic formation, osteitis fibrosis cystica, what is called the brown tumor in this area. This is a right swelling left knee joint, and so loss of density and multiple cyst formation. In these situations, more swelling in the right shoulder, and the patient complaining of mild cough and sneezing, complaining of rib fracture. Click and examination and X-ray show rib fracture is here. On February 2021, failed left fistula and inserted right internal jugular vermicath was so difficult, but the vascular surgeon inserted in high centers. This is the internal jugular vermicath, and this still the patient complaining of swelling of the right shoulder and soft tissue calcification, multiple cyst swelling, and the fragility fractures the shift of the left femur and the neck femur. Same, and the start vascular calcification at the femoral. This recent one, since 3 days. We show no bone. The bone changed to fibrous tissue, and also many cystic formation, and vascular calcification, femoral. And this is a recent one. Also mid shift of the left femur, fragility fracture, and also the neck and multiple swelling. This is the skull as book, and show a salt and pepper appearance, area of lucence, translucent and dense area of sclerotic area. This is a skull X-ray. This is a recent one also since 3 days. And this is the hand. If you comparison between this hand and the hand of 2020, more and more resorption, and this fractures, metacarpal, bone resorption, and as we see in the middle fingers, no middle and distal phalanx, no, it's resorbed. Also on the other finger, what's called acroosteolysis hand. This DEXA scan show also. From number 1 to number 4, -5, -6, -6, -7. And according to this neck, right, neck fever, right, left. When this is not measured, I ask the radiologist, why no measure? There is no bone at all. When the scanning of this area, no bone at all. This is fibrous tissue, greater trochanteric and lesser trochanteric and neck femur and shaft of the femur. The scan cannot measure, so not get zero, but cannot measure this density. Also, in the right femur, cannot measuring the metallic, but measuring this area and score -3.2. The Frax calculation tools not accurate because of the out of the age. From lab result and radiology finding and all revealed high turnover bone disease, secondary and tertiary hyperparathyroidism, and severe bone osteolytic finding, and severe hyperparathyroidism bone manifestation. The plan of management was try to start suppressions the hyperparathyroid activity and optimizations in biochemical activity, increasing the clinical set from 60 to 120 and follow up the PTH, and will increasing the dose of calcit, alpha calcidol, calcium carbonate, and civilamide. We try to add paracetamol, but not available in our pharmacy and also outside private pharmacy. Try to assessment the parathyroid gland scanning, but not available in our hospital, and we arrange to refer the patient to high center for parathyroid scan. Osteoporotic treatment will try after optimizations in biochemical activity by interface and start denosumab. But there is a dilemma of parathyroidectomy, indicated or not. And Professor Dr. Amr answered about this dilemma in the last lectures, but also we need comment or any recommendation from Dr. Amr. This is about the parathyroidectomy. This is our patient. Why parathyroidectomy? Because continuous elevation parathyroid, stop regressions, and this elevation symptomatic, but patient multimorbid disease and outcome, functional status, if the patient is able to stand general anesthesia or not. This slide I borrow from slides of Dr. Amr. Thank you.
Thank you, Dr. Said, for
any recommendation or any.
Thank you, Dr. Said, for this case. Actually, it's a classic case of persistent, long-standing hyperparathyroidism with all bone abnormalities, osteoid fibrosis, Roger spine, saltpeter skull. Actual patient has many fractures and unhealed fracture. It's indicated for parathyroidectomy, I think, but is it reversible for this case? All these abnormalities, can he benefit from parathyroidectomy? Maybe, but is he fit for surgery? I think he's not fit at all. Please, Dr.
Yes.
Amr, can you help us in this case?
Oh, yeah, interesting. Thank you so much, Dr. Said, for your presentation. I think it's too late to do anything. They usually say it's never late, but I think in this case it's too late. Again, severe refractory resistant, either secondary or tertiary hyperpara, doesn't make difference now. These patients in the last at least 11 years since 2012 has a BTH of over 1200. He has severe high turnover bone disease. And this is just an educational case. We are discussing this because actually when we started and initiated our CKD-MBD graduate certificate program, our intention was to prevent this devastating serious complication when we ignore controlling the renal osteodystrophy. So this is what happened to our patients. This patient, the most surprising thing in this patient is he's still alive. You know, with all of these fracture, with this severe cardiovascular calcification, and he's still alive. Of course, he has more than 20 years history of CKD. It seems that his CKD started much earlier than you know, when he started dialysis at age of 17, because he has what we call renal rickets. So his epiphysis is wide, he has genovalgum, he has pigeon chest, he has all manifestations of rickets that usually start early on during childhood periods. Probably he has a chronic kidney disease long time before he started dialysis. Probably he has it maybe for 10 years or more. And this is very typical for patients with tubular interstitial disease, like reflux nephropathy, chronic pyelonephritis. They have frequent UTIs. They still can make urine. Sometimes actually they are polyuric. Then they lose with the water, they lose the concentration ability. The renal tubules cannot concentrate, so they usually have hypercalciuria and also hyperphosphaturia. So they lose electrolytes, they lose minerals, and their renal osteodystrophy and renal rickets start very early on. We can usually start with osteomalacia or rickets with demineralization problems. So they have what we call it osteomalacia because the osteoblasts still lay out the collagen, but the collagen cannot mineralize. This started the process many, many years ago. Now he has full-blown picture of severe hyperparathyroidism with all the radiological findings, with all kinds of fracture and the associated cardiovascular calcification. So this disease should be controlled 20, 30 years ago. And now we are harvesting what we have planted in the last couple decades at least. His surgical, of course, he needed parathyroidectomy long time ago. Now he has very high surgical risk. Even if you intubate him, he can fracture his cervical spine because his bone is very, very soft. You remember he fractured his fingers, he fractured his femur, the long bones, and he fractured his ribs just with a cough. So if he fractured a rib with a cough, it doesn't surprise me that he can fracture his cervical spine with a procedure of parathyroidectomy. So I don't think any surgeon or anesthesiologist will be happy to operate on this guy. His surgical risk is very, very high. So bottom line, it's an educational case. I don't see anything that can happen that can help this patient. Is too late. If you try medical therapy, probably is not going to respond either because medical therapy of refractory hyperparathyroidism, we work on two things. We work on the calcium sensing receptor by giving calcium mimetic or vitamin D receptor by giving vitamin D receptor agonist. In the severe degree of hyperparathyroidism, there is severe downregulation of both the calcium sensing receptor and the vitamin D receptor. So he wouldn't benefit from maximizing and optimizing the medical treatment either. It's too late. There is a change of the polyclonal to a monoclonal gammopathy, a monoclonal proliferation of the parathyroid gland that is usually resistant to treatment. By that time, he usually have either single big adenoma or multiple small adenomas. If you do a systematic scan or even an ultrasound, you can see the nodules in his parathyroid gland. Again, it's just an educational case, and the take-home message is how to prevent. We need to start early. We need to work with the patient to convince him, because it's not only failure of our healthcare system, but also it's failure of the patient's compliance and adherence to treatment. We cannot just depend on ourselves, but we have to work in a multidisciplinary fashion. We have to convince the patient that if he doesn't control his bone disease, this is what he will end up with. The problem with the renal osteodystrophy, it's a slowly progressing problem. So the patient doesn't see the immediate effects. It takes months and years to see this devastating consequences. It's not like control of blood pressure or blood sugar, that when you take the medicine, your blood pressure goes down or your blood sugar goes down. No, you don't see that as an immediate effect. It needs time. In how to convince your patient to comply and to adhere with the medication and with the health care recommendations. This is another thing we need to focus on. It's not only the responsibility of the physician or the patient, it's multidisciplinary with the nurse, with the social worker, with the dietitian, with the dialysis technician. We all need to work together to prevent such devastating complications.
Thank you, Dr. Amr, for this fruitful explanation.
Question.
Please, everyone, mute yourself.
Okay.
Yes.
Now, let's move to the next case. Please, Dr. Said. Go ahead.
Shall we can ask now, or we will postpone the questions for the until end of the session?
Okay, doctor, please write your question in the chat box, please. So we have 2 minutes for any questions in the chat box.
Dr. Said Khamis is with us. Professor Khamis, do you have any comments or questions about this complicated case with very high risk of mortality?
Thank you, Professor Amr. Good evening for all, and I think for you, good morning, Zera. Regarding this complicated case, as you said, it is prevention better than cure. It should be prevented from the beginning on multidisciplinary basis, but unfortunately, it's too late to do anything right now. I think the message from this case is to start early, to start in a multidisciplinary fashion, and in the meantime, we should share with all the healthcare providers, as you said, dietitian, social worker, psychiatrist, dialysis technician, even the patient himself, he should share in this management with us. So it should start as early as possible, as you said, dear Professor.
Thank you so much, Dr. Said.
You're welcome, sir.
Thank you, Dr. Said. Do you have any problem during writing in the chat box, dear doctors?
Yes, there is a problem with chat disabled.
Okay, Dr. Ibrahim, you can ask your question.
we are my
Thank you. Sorry, why this patient was not managed early by parathyroidectomy, as over many years PTH was always elevated with secondary fractures and so on. So why this patient was not managed early by parathyroidectomy several years ago? He is a late presentation, but why it was not managed early? Thank you.
Thank you, Dr. Brahim. Dr. Said, do you have answer for this question? Okay, go ahead.
Yes, we referred the patient many times to high centers, king fat specialist, and the patient admitted. And sometimes the challenge is the patient and the family. يعني no compliance, and sometimes left against the medical advice, and sometimes taking appointment, and sometimes the patient neglect this appointment. Many times we refer the patient to high centers and admitted 1 week, 2 weeks, but left against the medical advice. For some challenge as social and patient and family and like that. So as my colleague mentioned, need a multidisciplinary team. يعني. Until now, the patient refused after fractures and after refused to go to any appointment to other hospital.
Thank you so much, Dr. Said. Another question by Dr. Amani Abdelgawad. She asks, is parathyroidectomy available in Saudi Arabia?
For sure, Dr. Amani, for sure.
available, yes.
Yeah.
Okay, I have another questions. I tried to put it in the chat, but it was disabled.
Now it is enabled by Amr already.
Go ahead, please ask your question.
Okay, in such case with advanced hyperparathyroids and advanced pictures with all bone manifestations, and do you think that this polypharma, he has a lot of medication, this patient he's taking cinacalcet, calcium, sevelamer, a lot of medication. Do you think we need to continue with such approach and to continue even the medical management of this patient?
It's a good question.
Let him dive.
It's good and tough at the same time. So
yes,
sometimes,
because a lot of things you are now giving him high dose of cinacalcet, and I am sure he will have some GI upset from this one, and you are giving him calcium, despite the calcium is now all the calcium, he has extra calcium load in his body, and you can see all these manifestation you are giving him. So I think maybe the medical approach, we need to go and minimize the medication. I think that, but I don't know.
I completely agree. I don't know if you're familiar with this concept. I can tell you different concepts. Sometimes we keep relation in our life just because we hate to stop it. It's unsuccessful relationships, but you cannot stop it because you don't want a failure, but also you're struggling continuing it, and you're not gaining anything from continuation of this relationship. It's called Concord fallacy, if you are familiar with this concept, because Concord, as a manufacturer, used to manufacture this Concord planes and lose a lot of money for almost 20 years. They cannot be brave and stop making these planes, and they were losing money and the resources on it. So sometimes, we do stuff, we cannot stop it. We don't know why we are doing it. We don't know what is the benefit of doing it, but it's hard not to do this actions or keep this relationship. So I think this might explain medical therapy in this patient. Probably he's not going to respond. Surgical treatment is too late. To say that it's too late and not to do anything and stop medical treatment, I think that's it needs a brave doctor and a brave healthcare system. I don't think anyone can do that, at least for now. So I think we need to keep this relationship despite it's not successful relationship.
Yes, yes.
Thank you very
Another
much.
another question in the chat box. Why is this patient on iron infusion about 800 milligram per month? And if this may contribute to his serious complications?
Dr. Said?
Yes. Yes, we stopped in this month. This is the last investigation. We stopped the iron parenteral iron after this investigation. Yes, we stopped already.
By the way, I have a quick comment about his failure of the AV fistula. And of course, also, he is not a candidate of kidney transplant for multiple reasons. But what I'm going to focus on now is the cardiovascular calcification. He is not a candidate because his surgical risk is very high. But the other thing is, with this severe cardiovascular calcification, it's a reason for failure of AV fistula because the blood vessels lose its elasticity and pulsatility. It's very rigid and tough. And as we know, the bone now is like a sponge, and the heart and the blood vessels are like rocks and stones. So one of the common complications that we don't usually focus on for renal ST dystrophy is failure of AV fistula. And also, he cannot get a kidney transplant because the iliac arteries that, or the inferior vena cava, or whatever you're doing the vascular anastomosis in, depending on his size or weight, is not going to work. It's not going to, heal because the blood vessel is just, calcified. So he cannot get a kidney transplant because of very poor vasculature. He can not have successful AV fistula because of the same reason. There is very good correlation between the renal osteodystrophy and the severity of cardiovascular calcification.
But Professor Amr is
the ignored. Go ahead, Dr. Said.
sorry, تفضل دكتور عمر.
Of course, the ignored part is that he most likely has erectile dysfunction. He has claudication. He cannot move because of the severity of vascular calcification in his legs and penile arteries as well. Go ahead, sir.
Thank you, sir. Actually, is there any powerful studies showed that there is a strong correlation between the fistula, AV fistula calcification and the AV fistula failure? If you have an idea, please, can you tell us?
It's an association. I mean, the reversed, to prove this concept, you need to reverse the process of calcification and see if this will help with the fistula maturation and survival. There is good correlation between severity of calcification and poor survival of AV fistula. So this is just an observational study, but to do to make sure that this is a causation, not an association, you need to reverse the calcification and see the impact on the blood vessel. So far, we don't have any way to reverse the calcification. There is subtrial that can delay the progression of cardiovascular calcification, but even kidney transplantation doesn't reverse the cardiovascular calcification.
Do you agree with me that the vascular calcification is an end-stage vessel disease?
I like this term. I never heard about it. I completely agree with it.
Okay, thank you, sir.
Yes, sir.
Thank you, Dr. Amr, Dr. Said. And now, please, let's move to the next case. Dr. Said, are you ready?
Okay.
Okay, go ahead.
Second case, 79-year-old male patient known as interstitial disease, long-standing diabetes mellitus, type 2 on insulin therapy, patient hypertensive, developed interstitial disease, initiated since 2021, since 2 years. Dialysis via right internal jugular premicath, if fistula creation also failed, weak thrill and if fistula and failed. Failed after flow, weak flow and thrill and failed. Course of the disease, the patient complaining of swelling of right upper limb, side of the internal jugular premicath. We suspected thrombosis or obstructions. Duplex study show no evidence of DVT and conservative treatment and subside edema. On June 2023, history of fall down, swelling left elbow but no fractures, generalized bony ache, lumbosacral and lumbar spine X-ray, and thoracic spine CT done. Radiology screening show Rogers jersey spine appearance and generalized sphere osteopenia. But the important finding extensive widespread vascular calcification noted involving visceral vessels branch. On in July 2023, the patient complaining or presented with blackish skin discoloration, right middle finger, distal phalanx with surrounding redness, progressed rapidly and increasing this blackish area, ischemic necrosis and distal phalanx of the distal phalanx of the middle finger, referred to surgical site and debridement and amputated distal phalanx. Investigation, leukocytosis, hemoglobin and hematocrit accepted and inflammatory marker present. Renal panel accepted also as end-stage renal disease. Hyperkalemia revealed in the lab. Bone panels, calcium 8.1, hyperphosphatemia, alkaline phosphatase high, borderline. Lipid profile, no abnormality, no hyperlipidemia. Glycosylated hemoglobin, poor control blood sugar, magnesium 1.9, vitamin D, the normal range, 116 nanomole. Liver panels revealed alkaline phosphatase high, 109. About the parathyroid hormone, the level 250, 190, 145, 44, 280. This is the serial assessment of the parathyroid hormone. The right upper limb show extensive vascular calcification. This is, we noticed this in this patient. As we see, this is the brachial and also radius and ulna. This right upper limb, radius and ulna, and this is the humerus, and also this is the vascular calcification, as we see. The CT show Rogers jersey spine. We see also this is the calcification of our aortic calcification and visceral calcification.
Can you go back one slide? Does he have a vertebral fractures?
Oh, in this spine, this
go down two spines down.
Yes.
1, 2, yes. This one is fractured.
Okay.
And this is not uncommon in dialysis patients to see non-specific vertebral fracture. These patients usually complain of chronic back pain, so the presentation is not acute, and you can just incidentally find that in the vertebral X-rays. Yes.
Yes.
And again, Rogers spine, you see the translucent areas alternating with the hypertranslucency or the sclerotic area. Yeah, go up one more, up one. Yeah, this translucence, this one, and two vertebrae Below that, go down one more, this one, right? So, and the end plates, the vertebral end plate are sclerosed, and inside the vertebrae, you see the cysts or translucent areas that's called rouge or jerseys. Thank you so much for that. That's typical sign.
This aortic part calcification and bilateral the renal vessels calcification in this CT. Pelvic vessels calcification. This is a lateral view. Also aortic calcification. This is a DEXA scan of this patient. Show number one, minus 2.5, 2.9, total 2.4 minus. Left minus 2.6, 2.2, and also the right 2.5 total, 2.4 minus 2.4. The Frax tools calculation. 10 probability of hip fractures 2.1 and the major osteoporotic percent 4.5. TBS cannot measuring in our hospital. I discussed with the radiologist. The machine cannot not have the modality of TBS.
Can you remind us,
This
Dr.
double
Said,
study
with
show
medications?
I will. ماشي okay. We'll come. According to the Doppler study show, brachial and ulnar and radial and ulnar arteries show diffuse atherosclerotic changes in the form of thickening intima and also the medial wall, complex with calcification and caliber stenosis. This is a brachial artery, linear calcification. This is the hand of the patient before amputate the middle fingers, the distal middle finger. This more vascular calcification, digital and all the vessels, as you see. Also in a radial and ulnar. This is a patient. To start ischemic necrosis as the distal fingers of the middle fingers, blackish skin, progressive rapidly. This is in July. And the surgical side depletment and amputate the distal pharynx. After amputation. This is a medication anti-inflammatory for the wound and antihypertensive, clopidogrel and treatment and powders for hyperkalemia and sevelamer and calcium carbonate and alpha calcidoid. And the patient on insulin therapy. This is the medication. About this patient, we try to ameliorate the risk factor of vascular calcification, try to treat mental hyperphosphatemia of the patient by sevelamer and calcium carbonate, diet control, blood sugar control. We requested for protein C and S. We suspected calciflaxis. Also, the most area outside of the calciflaxis abdomen and the proximal lower extremities, but the calciflaxis also reported in uncommon sites like penis, like wristlet digits. Why we suspected? Because many risk factors present, like massive general vascular calcification, digital calcification, most common suspected chronic kidney CKD-MBD, old age, poor control blood sugar, calcification medial layer of arterioles and small arteries, diffuse calcification of small arteries and the capillaries of the affected hand. But unfortunately, the biopsy not done. So, punched biopsy to rule out or confirm the diagnosis. We try to follow the patient at any time can get biopsy will do. According to this patient, also we discuss about this patient about the CKD-MBD. This patient considered low turnover bone disease or high turnover bone disease. What about the osteoporosis? The BTH borderline alkaline phosphatase, hyperphosphatemia, normocalcemia. We try to request for bone turnover marker, but bone-specific alkaline phosphatase and TRAP 5P, but unfortunately none available in our lab. يعني any comment for or any recommendation for the pharmacological medication, also about the DEXA, about the osteoporotic medication. It can start, or the patient need bone biopsy. This is some issue confused in this patient. And we need also the recommendation from Dr. Amr and our colleague.
Thank you, Dr. Said, for this case. Another case of vascular calcification that has many contributing factors, starting from the age of the patient, diabetes and renal impairment. But there are many studies about role of vitamin K and magnesium in retarding vascular calcification. And we have Dr. Shrouk Nagar, lecturer of nephrology, Mansoura University, Faculty of Medicine. Dr. Shrouk.
Thanks, Bob. I think this is also another advanced case of vascular calcification. I think we should first define the state of bone turnover in this patient, because if this patient has a low turnover bone disease and we give anti-resorptive medication, we will exaggerate this state of low bone turnover. So in my opinion, I think we may need bone biopsy to define the state of bone turnover, and we may also hear the opinion of Dr. Amr. Regarding vitamin K, actually the evidence regarding the use of vitamin K to prevent or to reverse vascular calcification depend on observational and experimental studies, but clinical trials didn't show this beneficial effect. But we may give it a try. We don't have anything to lose. It will not reverse the already present vascular calcification, but it may prevent the progression, because experimental evidence reported it can prevent the transdifferentiation of vascular smooth muscle cell. Also regarding magnesium, observational studies reported a negative correlation between serum magnesium level and the hazard of vascular calcification. We have a large Japanese cohort that reported a U-shaped relation between serum magnesium level and the cardiovascular mortality. So this study advocated to keep serum magnesium between 2 and 2.5 milligram per deciliter as the best target for vascular health. So we also may give the patient magnesium supplement, but keep an eye on serum magnesium level and avoid hypermagnesemia. Thanks.
Thank you, Dr. Shrouk. I think
may I ask you about the sodium thiosulfate?
Yeah.
Yes, I think this patient might benefit from sodium thiosulfate, but we have to give it in a modified dose, as this patient has low GFR, and we should also adjust the dose according to his weight. After we give sodium thiosulfate, we should keep an eye on this patient arterial blood gas to avoid the occurrence of any high anion gap metabolic acidosis.
Yes.
Is the high anion gap metabolic acidosis complication common or rare with using sodium thiosulfate in our dialysis patients?
No, I think it is not very common, but it's an adverse effect that was reported, and we should guard against it.
Very good, very good. Thank you. So again, this is another spectrum. So here, this is long-standing diabetic old guy. The first patient was young, and everything was related to his CKD, that's secondary to his tubulointerstitial disease pyelonephritis at very young age. So all the bone complication, all the vascular complication were related to his renal osteodystrophy. But in this case, I think the dictating comorbidity was the diabetes. The diabetes was the leading cause of end-stage kidney disease. Diabetes and atherosclerosis and the metabolic syndrome was a leading cause of vascular calcification. I wouldn't be surprised if the calcification here is both intimate and medial. The first patient probably has more medial calcification.
Yes,
Again,
this is intimate.
this is a combination of both, I would say. The other thing is, as Dr. Saeed asked me for the first one, I think this case also augments the problem with failure of AV fistula again with severe cardiovascular calcification. We have some questions here. I think first of all, what kind of bone disease or renal dystrophy has? Is it low? Is it high? Bone turnover? Is it osteomalacia? Is it mixed uremic osteodystrophy? So that's a question. The other question would be, is this a real calciphylaxis without doing a skin biopsy? Are you sure that this is a calciphylaxis, not severe peripheral artery disease? I think I would treat it anyway as calciphylaxis. It doesn't matter. It's a combination of calciphylaxis induced severe or happen because of the severe peripheral vascular disease, which is mainly here because of the calcification. Could be a combination of atherosclerosis and calcification. But anyway, I would start sodium thiosulfate on him. I will optimize his diabetes and other